Well, thank you very much for the kind invitation. Can you see my slides?
Yes, we can see.
Okay, thank you. So the title of my talk is Unmet Needs in Acute Coronary Syndrome, focusing on the potential of factor 11A inhibition. I'm not able to move my slides. Can someone help me, please? Let's see, maybe I can do it now. There we go. These are my disclosures. And let me just take you quickly through the timeline of development of the oral anticoagulants. It's hard to believe that it's 15 years since the introduction of the first direct oral anticoagulant, dabigatran. And now, 15 years later, we're getting better at using these agents. They've taken over from vitamin K antagonists like warfarin, but we still have problems. Remember that the ultimate goal of anticoagulant therapy is to attenuate thrombosis without increasing the risk of bleeding. And although these agents come closer to this goal than warfarin, we still have high rates of major and clinically relevant non-major bleeding in phase 3 trials and in the observational studies in the atrial fibrillation population. And unfortunately, the bleeding or the fear of bleeding has led to the systemic underuse of anticoagulation in eligible patients with atrial fibrillation. Even the most recent registries suggest that at least 40% of patients are not receiving an oral anticoagulant. And even when oral anticoagulants, the direct oral anticoagulants, are prescribed, there's often an inappropriate overuse of the lower dose regimen. And both of these phenomena lead to unprotected patients. Now, I just want to remind you that coagulation can be initiated through two distinct pathways. There's the tissue factor pathway that's initiated, for example, when atherosclerotic plaques rupture. And then there's the contact pathway that's initiated when blood comes into contact with a negatively charged surface, such as a mechanical heart valve or a central venous catheter or a coronary stent. And these two pathways converge at the level of factor 10 on the common pathway. Now, all of our current anticoagulants target either factor 10A or thrombin or both, but now the interest has moved upstream to the level of factor 11. And let me explain why. The concept here is that by targeting factor 11, we can uncouple hemostasis from thrombosis. So hemostasis is the process by which we stop the blood loss from an injury to the blood vessel. And this is a mostly extravascular event that's triggered by the high concentrations of tissue factor that surround blood vessels, the so-called hemostatic envelope. This exposure of this large amount of tissue factor triggers explosive thrombin generation and clot formation, and factor 11 is mostly irrelevant for this process. Now compare that with what I show on the right-hand side here, which is thrombosis. This is an intravascular event. Here I show it being triggered by a ruptured atherosclerotic plaque, which exposes a small amount of tissue factor and results in the generation of a small amount of fibrin that quickly covers up the injury site and blocks access of the blood to tissue factor. In order for that clot to grow and to expand to the point where it blocks blood flow, the thrombin feeds back, activates factor 11 to generate more factor 10A and more thrombin. So our current anticoagulants, the direct oral anticoagulants and warfarin for that matter, target the common pathway involving either factor 10A or thrombin or both. And because the common pathway is essential for both thrombosis and hemostasis. These agents inevitably lead to bleeding. In contrast, our factor 11A inhibitors target factor 11A, which is mostly redundant for hemostasis, but essential for clot growth. So in this way, by targeting factor 11, we can uncouple thrombosis from hemostasis and thereby potentially reduce the risk of bleeding. Now, there is considerable evidence that suggests factor 11 is essential for thrombosis, but mostly dispensable for hemostasis. Persons with congenital factor 11 deficiency have a reduced risk of thrombosis, but they rarely experience spontaneous bleeding. Genetic epidemiology studies tell us that the risk of thrombosis is twofold higher in individuals with high factor 11 levels compared with those with normal levels, and lower in those with reduced factor 11 levels. And studies in animals, whether they're rodents or non-human primates, show that factor 11 knockout or factor 11 inhibition attenuates thrombosis in arteries or veins in a dose-dependent manner, but there's no increase in bleeding. So this is very different than the results in animal studies with the DOACs, where increased dose resulted in increased suppression of thrombosis, but also an increase in bleeding. Now, our factor 11 inhibitors that are in advanced stages come in three categories. We have antisense oligonucleotides and now siRNAs that reduce the synthesis of factor 11. We have monoclonal antibodies that block factor 11A activity, block factor 11 activation, or block factor 11 activation and activity. And we have small molecules which, like the DOACs, bind reversibly to the active site of factor 11A and block its activity. And the two small molecules that are most advanced are asundexian and milvexian. Now, the development of new anticoagulants usually starts in patients undergoing orthopedic surgery, because dose finding can be done in such patients using a venogram, an X-ray of the veins, as a method to detect thrombosis. And thereby you can find out what doses of the different anticoagulants reduce the risk of venous thromboembolism after knee arthroplasty compared with the comparator. And the comparator is usually the low molecular weight heparin, enoxaparin. And you can see we've had already 4 trials in this indication, one with the antisense oligonucleotide, 2 with antibodies, asocimab, which blocks factor 11A, and abelacimab, which blocks factor 11 activation and activity, and 1 with the small molecule milvexian. And in this meta-analysis, you can see that compared with enoxaparin, the factor 11 inhibitors are associated with about a 40% reduction in the risk of postoperative venous thromboembolism and about a 60% reduction in the risk of clinically relevant bleeding, which is the composite of major and clinically relevant non-major bleeding. So this shows the promise of the factor 11 inhibitors to be at least as effective, if not more effective, than currently available agents, and to be associated with a lower risk of bleeding. Now, I've been asked to talk about acute coronary syndrome, and here is a list of the phase 3 trials with factor 11 inhibitors that are currently ongoing. Abelacimab is being studied in 3 indications, or 2 indications, in patients with AF, where it's being compared with placebo in subjects who are considered not to be candidates for currently available oral anticoagulants, and in patients with cancer-associated venous thromboembolism, where abelacimab, which is given subcutaneously once a month, is being compared with apixaban in the ASTRA trial and dalteparin in the Magnolia trial. Asundexian, one of the small molecules, was being compared with apixaban in patients with atrial fibrillation in the Oceanic AF study, and with placebo on top of antiplatelet therapy for secondary prevention in non-cardioembolic stroke in the Oceanic Stroke study. As you all know, the Oceanic AF trial was stopped early because of a lack of efficacy. I'm not going to dwell on that, but I'm happy to answer questions about that in the discussion period. Milvexian is being studied in 3 indications. It's being compared with apixaban in the Librexia AF study, and it's being compared with placebo on top of antiplatelet therapy in the Librexia Stroke and Librexia ACS study. And I'm going to spend some time now talking about the rationale for the Librexia ACS trial. So current guidelines for treating ACS focus on antiplatelet therapies. But despite even dual antiplatelet therapy, even with more potent P2Y12 inhibitors, there's still a high risk of ischemic recurrences, possibly due to persistently increased thrombin generation. So the question comes up, is there a need for more antithrombotic therapy for such patients? We know from the COMPASS trial that in patients with stable coronary artery disease, the addition of low-dose rivaroxaban, that's 2.5 milligrams twice daily, on top of aspirin, reduced the risk of ischemic events by about 25% compared with aspirin alone. However, this regimen increases the risk of bleeding by about 66%, although not life-threatening bleeding. So the problem we have is that antiplatelet therapy alone leaves thrombin generation elevated after acute coronary syndrome, and this elevated thrombin generation can persist for months or years in patients with coronary artery disease. And the antiplatelet agents do not block thrombin generation. Increased thrombin generation is a bad actor because it's associated with an increased risk of recurrent ischemia, and it's also associated with a more than 3-fold increased risk for cardiovascular death. Now, the problem with the currently available oral anticoagulants is that, like low-dose rivaroxaban, they can reduce thrombin generation, but this reduction comes at an increased risk of bleeding, which prohibits their use. So the risk, when you add an oral anticoagulant to single or dual antiplatelet therapy, the risk of bleeding goes up by about 2 to 3-fold. Now, if we focus on COMPASS and look at vascular events, the addition of low-dose rivaroxaban to aspirin reduced major vascular events in patients with stable coronary artery disease. Remember that after a run-in period, patients in the COMPASS trial were randomized to rivaroxaban plus aspirin, to rivaroxaban alone, or to rivaroxaban or to aspirin alone. And the primary outcome, cardiovascular death, MI, or stroke, was reduced with the combination of rivaroxaban plus aspirin, which led to early termination of the study because of efficacy. And that combination also reduced cardiovascular mortality by about 20%. We know from the ATLAS trial that looked at rivaroxaban on top of antiplatelet therapy in patients with an acute coronary syndrome, that again, the combination of rivaroxaban on top of antiplatelet therapy reduce the risk of cardiovascular death, stroke, and MI, again by about 15%. And lower was better. The 2.5 milligram twice daily dose on top of antiplatelet therapy also reduced cardiovascular death and all-cause death compared with placebo. The problem was that that combination also increases the risk of bleeding, and increased bleeding results in an increase in 30-day all-cause mortality and an increase in the 30-day risk of MACE, likely because patients who have bleeding have their antithrombotic therapy stopped and they have recurrent cardiovascular events. So the Librexia ACS study is a phase 3 cardiovascular outcome trial of milvexian versus placebo in patients with acute coronary syndrome. So these are ACS patients post-revascularization in days 1 to 7. They're on background dual antiplatelet therapy, and they're randomized to milvexian at a dose of 25 milligrams twice daily or to placebo. The estimated enrollment is 16,000 patients, and the trial timelines, the trial started in 2023, 2024, and it's expected to finish in 2026. The primary endpoint is MACE, and it's powered for a 20% relative risk reduction with milvexian compared with placebo. Enrichment criteria are used to ensure the recruitment of higher risk patients. These enrichment criteria include clinical factors such as older age and diabetes and a history of prior MI or multivessel coronary artery disease, as well as high risk angiographic features. The patients are stratified according to the predefined antiplatelet strategy into those that are going to receive a greater than 90-day course of dual antiplatelet therapy, those who are destined to start with that with de-escalation within 90 days, and those who are destined to single antiplatelet therapy alone. In each stratum, patients are randomized to milvexian or to placebo, as I described earlier. So the key takeaways from my presentation are that patients with ACF have a significantly higher risk of recurrent cardiovascular events than those without acute coronary syndrome. Antiplatelet therapies alone are insufficient because thrombin generation remains elevated and bypasses the main effect of the therapies, especially the antiplatelet therapies. Combining antiplatelet agents with current oral anticoagulants is limited because of the increased risk in bleeding, but as I've shown you, factor XI inhibitors may be safer than current oral anticoagulants, and that's what we are testing in the Librexia ACS study. I'll stop there, and I thank you for your attention.